publishers, I did invite you almost to Lisbon. So start with a question. So would you put your 78-year-old uncle on ECMO for protected PCI or after cardiac arrest? Show of hands.
Uncle, yes.
So yeah, a few, and who would not? So the rest, I guess. So a lot. So pretty conservative. So yeah. So let me just put this, because I had a laugh when I did another ECMO talk earlier this year. My research took me back to 1812, and actually there's a French, John Caesar, who actually already explained the principle of ECMO. And so you see here this pure rapid, and he says if you could infuse continuously with a blood or a component that looked like blood, then you could basically live forever. So maybe, you know, if you do artificial MCS, maybe we could all live forever on ECMO or the like. What's happening with ECMO over time? Well, we certainly see that it's been growing tremendously after the EIBP shock trial, when we stopped doing balloons, certainly in Germany, but also on the right, you see in other countries, a huge increase in the use of ECMO. You also see on your right side that the age groups now, at least in Germany, over 70 account for 30% of the cases. So octogenarians is not that rare that they get ECMO, and certainly there's a lot of patients over 70 who get ECMO. And the question is whether it's justified. If you look at real life versus trials and look at the inclusion criteria, just look down here what I have shown you in red. Age, you can see here that in IABP shock 2, the danger shock, and the ECLS shock with the different colors, you can see here that age in IABP and ECLS shock had an age limit, whereas in danger shock, there was no formal age limit to implant the Impella device, as we heard earlier this morning. But age does come into play, and if you look at the bottom in green, you can see here that not only age, but also the other exclusion criteria, but also, of course, inclusion criteria that are strict, result in that only a minority, less than 20% of patients actually, of all comers, are actually eligible for the study. So you also have to be cautious when interpreting the indication for an MCS, because a lot of the patients that you will see on a daily basis, about 80%, were not represented in the trials. So there's still a lot of doctoring out there to be done. So just if you look at this meta-analysis that were published in The Lancet last year, and I apologize, I think actually the presentation was done by Holger Uwe, and you were the first author, right? Okay, so my mistake, I'm sorry. But so of course, one of Uwe's great contributions to science here, and you can see here in their subgroup analysis of the meta-analysis of all MCS trials, you can see here that age actually above and below 70 was not that different, you know, if anything, pushing it hard. You see a trend towards MCS better in the more than 70-year-olds, but there's the P for interaction is certainly not approaching significance. So if you look at some studies that have been published, single center studies, you see the same observation. These might be selected cases, patients here showing, maybe because of lack of power, that no difference, statistically significant difference between patients below and above 70 in terms of outcome when treated by MCS. But some of the more recently published data actually that have been done was from the dangerous shock trial that we published a couple of years ago. This has been presented as abstract. And you can see here, certainly if you look at age as a strict criteria, if you look at your survival curves, Kaplan-Meier on the right, you can see that there's, of course, a very high mortality in the elderly patients, with those being more than 77 years of age. You have an almost acute, immediate, within a few days, mortality of about 30%. And if you look at multivariable indicators of survival with or without MCS, you can see that certainly age above 70 is a significant factor. You see that on the right. And of course, then also, not unexpectedly, the patients who are then approaching 80 and above. So age does come into play. And in this sub-study by Dr. Klein, you can see here that in the quartile, so the same number of patients in all four groups, those between 31 and 59, 60 to 69, 70 to 76, and 77 to 92 being the oldest patients, the lines sort of cross. When you get above 75 years of age, out here in the third quartile, you see here that there's a steep increase in mortality. But also, this very old contingent of patients, which at least does account for 25% of the population in this study, is also a different species, if you wish. So there are a lot more women over in this group, a lot more women in the elderly group, and there have significantly less resuscitation as a couple of features that are very specific in the very high age, at least in the danger shock trial. So looking a little bit more scientifically about it here, including the confidence interval, you can see that there is sort of in the middle here a sweet spot where compared to conservative treatment for cardiogenic shock, MCS with the impeller device certainly has its merit. And then you cross the line of identity at about the age approaching 75 to 80. But as you see, as we have less patients out here, there's also a very wide confidence interval. So the confidence interval is huge. So I think this also, even in the context of a trial, speaks to some individual assessment in these patients. So talking about ECMO and MCS in general in patients who have an indication, very modern, of course, is eCPR protocols. So this is a meta-analysis showing a rather complex Sankey diagram published last year in Resuscitation. I only actually want to focus on the purple part of this, but just to show you that in many eCPR protocols, the usual age criteria in most centers, published centers, is 75. Those are 24 centers with reported outcomes during eCPR, and 18 centers actually used a criteria of 70 years of age. And you see there are a few that actually go all the way up to 80 on the top. So just to show you, this is sort of the usually accepted criteria in most university centers for eCPR is between 70 and 75 years of age for doing eCPR with ECMO. So I think there are some exceptions to age limit, and those are complications, mainly the ones that we as doctors do to our patients in our best efforts to care for them. And the old philosopher and Dr. William Osler said the patient who takes medicine must recover twice, once for the disease and once for the medicine. So it is well known that all our procedures, all our medications have their side effects. But I think on the bottom, I think if you have iatrogenic complication, I think you should actually really widen the spectrum and try to salvage the patient. And I don't think there should be any real age limit if it comes to coronary perforation or other situations during implantations of valves or in the coronaries. So my take-home message is that MCS use in the elderly is certainly increasing. This has been documented. And elderly patients, of course, do present with more high-risk features. The usual ECPR limit is 70 years of age, going up to 75 in some centers. And one size fits all, as the statement does not apply to MCS and cardiogenic shock, and you really need an individualized approach. And I think age is just one variable in this very complex equation. Thank you for your attention.